Distinguished faculty and esteemed delegates in the Endo-Physician Interconnect webinar. I also welcome our medical director, Dr. Gurunath, and request him to introduce chairpersons and so that to take on further proceedings of the EPIC. Over to you, Dr. Gurunath.
Yeah, thank you so much, Mr. Pandita. Once again, welcome on behalf of Samarth Life Sciences, and this is the sixth session in the EPIC series of webinar, and we have eminent chairpersons and international experts as well as speakers. Introduced Professor Dr. Rakesh Sahai. Dr. Rakesh Sahai is a professor and head of Department of Endocrinology, Osmania Medical College and Hospital. Sir has been Vice President, Endocrine Society of India, Asian Federation of Endocrine Societies. Sir is also Vice President at AIAARO and Executive Committee member of National RSSTI. Sir has been also chaired various prominent positions as former Secretary Endocrine Society of India, Founder Secretary South Asian Federation of Endocrine Societies, former Chairman of the API chapter of RSSTI and Hyderabad chapter of API, Associate Editor of Indian Journal of Endocrinology and Metabolism. Sir has also received various prestigious awards, including Fellowship of the American College of Endocrinology in 2009. Sir has also received Senior Lectureship Oration Association of more than 130 publications and authored chapters in various textbooks and monograms. Sorry for the interruption. I will hand over to Professor Dr. Rakesh Sahai for the further questions. Thank you, sir.
Thank you, Dr. Gurunath, for the kind words of introduction. I think it's a pleasure to be here today on this sixth in the series of webinars that we've been having on focused on the adrenals, and we are thankful to Samarth Pharma for sponsoring this event. And I think we had very interesting sessions earlier also. I'm sure all the audience who are attending this program have attended the earlier programs also, and have really gained information, a lot of information from the earlier webinars. So this is, as I said, is the sixth in the series, and today's discussion is going to be focused on adrenal incidentalomas, which are again a very common problem, which are seen by a variety of specialists, and particularly and in a various different scenarios we see this problem. And this is often I mean, what has to be done is often a dilemma. So we are going to have a excellent discussion today. We have with us we are very indeed very happy to have with us Dr. Vivian Lin, who's currently the president of the Asian Federation of Endocrine Societies. She has graduated from the National University of Singapore, and she has done her MRCP and Masters in Internal Medicine in Singapore, and is accredited as a specialist in endocrinologist as well as a fellow of the Academy of Medical Sciences in Singapore. She's been on the Executive Committee of the International Society of Endocrinology. She's has been the president of the Endocrine and Metabolic Society of Singapore from 2016 to 2018. And she was also the honorary secretary of the Osteoporosis Society of Singapore from 2016 to 18, and currently is on the executive committee of the Osteoporosis Society of Singapore. She's also the chair of the upcoming ICE conference, which is going to happen, the International Conference of Endocrinology, which is going to happen in 2022 in Singapore. And she holds she holds several. She was previously a peer coordinator of Doctors Without Borders in Singapore. So she has been very active in the field of endocrinology, and she has been active in the International Society of Endocrinology and in the Singapore Endocrine Metabolic Society of Singapore. So we have great pleasure in welcoming her to this webinar, which she's going to co-chair along with me. And to co-chair the session, we also have Dr. Pramod Gandhi. Dr. Pramod Gandhi is well known to most of us. He's from the city of Nagpur, and he is a consultant endocrinologist at the Kingsway Hospital in Nagpur. He's a very senior endocrinologist who has been in the practicing in the city of Nagpur for more than 2 decades now. And he's been the secretary of the that is the Maharashtra Society of Endocrinology, and he has been part of the executive committee of the Indian Society, Endocrine Society of India. He was, the conference of the Endocrine Society of India, the National Conference of Endocrine Society of India, SECON 2019, was held under his guidance, and he was the organizing secretary for that conference. It was very successful, very well attended, and very well organized. He's been the past president of the AMS Society in Nagpur. He's been past president of the Diabetic Association of India, of the Nagpur branch of Diabetic Association of India, and he's been very active as a faculty member in several different programs. He's been faculty at the CCEBDM, that is the Certificate Course in Evidence-Based Diabetes Management, and as a judge at the various awards functions like the A.V. Gandhi Award, the ESI TISA program, and all many other programs. He has been very active in clinical research. He has conducted several phase 3, phase 4 trials in diabetes and osteoporosis, and we have great pleasure in welcoming him to this program today.
Thank you, Rakesh.
That's Dr. Sameer Agarwal also, who's a very active endocrinologist and very academically active endocrinologist from the city of Rohtak in Haryana. He is currently the head of endocrinology and metabolism at EPIC-6 Super Specialty Hospital in Rohtak. He was at the PGIMS Rohtak earlier, and he has done his DM in endocrinology from All India Institute of Medical Sciences. And currently, he is also the president of the Speed Society. The Speed Society is very, very popular, very well known to most of us, because the society is, this is the Society for Promotion of Education in Endocrinology and Diabetes. So they had a very successful program held recently last month. They had a very well attended program, and he, apart from this, he's also a MCI recognized PG teacher. He has received several awards, some of them being the A.V. Gandhi Award for Best Research in Endocrinology. His main area of interest is in metabolic bone diseases, osteoporosis, pregnancy and hormonal disorders. And he has been editor of several manuals, the important of which are the insulin manual and the clinical manual on SGLT2 inhibitors, and also he has edited a manual on pregnancy and thyroid disorders. So pleasure in welcoming him also to this program. And then we have with us a very young and upcoming bright endocrinologist from the city of Bangalore. She has Dr. Sowrabha Bhat, who's going to present an interesting case and initiate the discussion today with all these experts who are with us here today. She has done an MBBS from JNMC in Bengaluru, Belgaum, and did MD in general medicine from Bangalore Medical College, and then went on to do her DM in endocrinology from the prestigious GMER Institute in Calcutta. And she has recently completed her DM in endocrinology and has been very active and has now settled down in the city of Bangalore. And she is presently consultant endocrinologist at the Chinmaya Mission Hospital at Bengaluru. She has co-authored a book on MCQs in endocrinology for the DM entrance examination. So all those who are looking out for doing doing a DM in endocrinology, they should look at her book, and that I'm sure this is going to help them a lot in terms of getting into DM in endocrinology. So with these words, I would like to welcome all our chairpersons and panelists, and I would before I request Dr. Sowrabha to present the case, I would like to have a few words from my co-chairs, Dr. Vivian,
Hello, greetings from Singapore. It's wonderful again to be able to meet all of you, despite the situation with COVID that it is now. And I was just talking to my co-chairs and wondering when can we ever be able to personally meet up. It's always wonderful that people are interested in adrenals. And to me, I mean, diabetes, obesity, these are really bread and butter. Thyroid, but adrenals and pituitaries are really very sexy things. But adrenal incidentoma is really something that we're going to see very often nowadays, because every single person in Singapore gets a CT scan. You know, they just don't even think about radiation. It comes in, it's a CT scan, doop, you have a small little 0.5 centimeter nodule in your adrenal. What are you going to do with it? So these are questions that keep popping up into our mind. And then if the 20-something-year-old person comes to you or 30-something-year-old comes to you and you have got this small adrenal nodule, what are you going to do with them for the rest of your life? You know, so these things are things that we, think about in our practice.
So thank you. We will definitely be discussing more about this, and we'll be learning more about this from Dr. Vivian and other co-chair, my other co-chair, Dr. Pramod Gandhi. I would invite him to say a few words before we move on to the case presentation. Dr. Pramod, you're muted.
Yeah. Thank you, Rakesh. I feel it's a wonderful session which has been organized by the Samarth Life Sciences. And we are seeing a lot of patients with adrenal incidentaloma, especially with the recent data which was shown by Dr. Yang, that we see almost 5% of the patients with hypertension has Conn syndrome. So that's a huge number. And that's the reason many of our hypertensive patients are undergoing CT evaluation if it is not controlled. And we are picking up a lot of patients with adrenal incidentaloma. So how do we go ahead with these patients? That's what we are going to discuss today. Thank you.
Thank you, Dr. Pramod Gandhi. Dr. Samir is ready to say a few things, I suppose.
Thank you, sir. I think we have the best faculty on board today, and I think it's an honor to have Dr. Vivian joining from Singapore. Thanks, ma'am, for being here, and I think we should straight away go to the straight case presentation so that we learn something today. And I find so many attendees also today logged in for this webinar. I think, yes, we must discuss these hardcore endocrine problems and how to approach a case of adrenal incidentaloma. Thank you all.
Thank you, Dr. Sowrabha. Yeah, you can mute and share your screen.
Good evening, respected teachers and all the participants. So I'm here to, I hope I'm audible.
Yeah.
Yes. So let's begin. I'm here to present two interesting cases of adrenal incidentaloma. Just one slide on what it is. That is the introduction. An adrenal incidentaloma is an asymptomatic adrenal mass which is detected on imaging, which is not performed for suspected adrenal problems. That is, the symptoms don't directly suggest an adrenal lesion. So here in this table that has been taken from the European Journal of Endocrinology guidelines of 2016, we can see the frequency. So if we look here, the most common group is the adenomas, of which the non-functioning adrenal adenomas are the most common incidentalomas that are found. Of course, the pheochromocytoma, adenocortical carcinoma, and also metastasis and myelolipomas are the other causes. Coming to the prevalence, in autopsy studies, it reaches almost 6%, and in abdominal CT up to 4%, the prevalence of incidentalomas these days because of the more investigations done on patients. So coming to the first case, she was a 52-year-old lady for whom for the evaluation of urinary tract infection, ultrasound abdomen was done, and a large right adrenal mass was found. She was a known case of hypertension, but that's not what she came with actually, which were well controlled with the two antihypertensives, amlodipine of 5 mg and metoprolol of 25 mg. And going deeper and asking her the history, she gave a past history of recurrent hypokalemia, which was actually managed with supplementation, but which was never evaluated in local hospitals. She used to get it treated, corrected, but it was not evaluated. On examination, just I'm mentioning the relevant findings. The heart rate was 90 beats per minute and the BP was 130/90. There were no obvious Cushingoid features. Other examination was totally unremarkable. Coming to the important biochemical investigations, only I'm going to mention. So the serum creatinine was 1.1. The sodium was normal in her. Potassium was 2.9 milliequivalents per liter. The ONDST 1 mg overnight dexamethasone suppression test was done, and the cortisol was a little high. It was not suppressed, 5.5 microgram per deciliter. The serum aldosterone concentration was 142 nanogram per dl, and this renin is 0.5 actually. 0.5, that is micro international units. Sorry, it looks like milli. It's micro international units per ml. And aldosterone renin ratio was 285 nanogram per deciliter per ml. Of course, the beta blocker was not stopped before this. It was obvious with the aldosterone concentration, which was very high. And she underwent a CT abdomen, CT adrenal, which showed a right adrenal mass of 3.3 into 2.2 centimeters with an attenuation of 3 Hounsfield units, which suggested adrenal adenoma. We can see the arrow pointing there. This was an unenhanced CT. So it clearly shows it is less than 10 Hounsfield units. So it looks like an adenoma only. We made a diagnosis of Conn syndrome caused by aldosterone producing right adrenal adenoma. Actually, at that point of time, AVS and all was not being done. And she opted for surgery, and also she had recurrent episodes of hypokalemia. So we prepared the patient and she underwent laparoscopic unilateral complete adrenalectomy, and the HPE was suggestive of adrenocortical adenoma. And post-operatively, the potassium normalized and the hypertension was mild and it was controlled with a single antihypertensive agent. So on follow-up, she did not have any episodes of hypokalemia. Now I'll proceed to the second case before the discussions. Second case was a lady, Mrs. LM, a 35-year-old lady. She complained of constipation and dull aching pain abdomen, which was on and off and chronic from 2 years. She was on presentation, she was diagnosed first time to be hypertensive. Again, here, actually in our setup, in both the patients, it was diagnosed with ultrasound only. Ultrasound picked up a right adrenal mass. Coming to the relevant investigations, she underwent 24-hour urinary metanephrines, and which was high, 496.8 microgram. And the cutoff is actually for metanephrines 400, so it is high, slightly high. And the 24-hour urine normetanephrines was more than 5,400 microgram, and the cutoff is actually 900. So predominantly the normetanephrines were found to be high. The sodium was 134, potassium was 3.7. The ONDST, that is overnight dexamethasone suppression test, it was suppressed, the cortisol was suppressed. The electrolytes were unremarkable. Actually, looking back after this on examination, there were no neurocutaneous markers or nothing obvious in the patient. She underwent the CT abdomen, and the CT images I don't have actually. The MRI was done. CT was done in another setup. Here MRI was done, and it showed a 9.2 into 8.3 into 7.4 centimeter SOL in the right adrenal. Sorry, there's a mistake there. Right adrenal with necrosis and peripheral solid areas with displaced right kidney. And on T2 hyperintensity, we can see that it lights up. That is the light bulb sign, typical classical of pheochromocytoma. So right adrenal pheochromocytoma was the diagnosis that was made. Patient underwent surgery after pre-op preparation. We use the alpha blocker, that is prazosin, in our setup. And after that, beta blocker was started, and high salt is also given. And she underwent surgery. And on HP histopathological examination, it showed classic Zell-Ballen pattern suggestive of pheochromocytoma. This was a picture of the slide, which shows cell nest and in the Zell-Ballen appearance. Post-surgery, after about 2 weeks, the metanephrine urine, 24-hour urine metanephrine was repeated, which normalized, and hypertension actually improved post-surgery. So these were the 2 cases. Other than this, we see a lot of incidentaloma, but most of them are non-functional. The key messages that we concluded from these 2 cases are that most adrenal incidentalomas are non-functioning and benign, but as per protocol, appropriate endocrine screening and treatment can be potentially life-saving for the patient. Thank you.
Thank you. Thank you. Could you also tell us what would be the approach if you had seen a smaller lesion and what would be the approach in that patient? I mean, in both these patients, there was hypertension, and we had definitive problems, and they were treated very well. But just for the information of the audience, we would like to know that if it is truly an incidentaloma where there's no hypertension and the person is otherwise asymptomatic and has a CT scan for some other reason and finds a adrenal mass, what would be the characteristics that you had in the mass? Whereas here, both of them had reasonably big masses. So
Yes.
give us an idea about this, about the size of the mass and how you would go about it in terms of imaging, CT.
So I have to say mention. Yes, sir. Actually, first the imaging gives us a clue. Actually, usually the adenomas are all less than 3 centimeters in size, most commonly. Pheochromocytomas are more than 3 centimeter, and adenocortical carcinomas are usually more than 4 centimeter. That is a cutoff for suggesting malignancy. Then, based on the Hounsfield unit, actually the unenhanced the CT Hounsfield unit, 10 is the cutoff actually. Less than 10, we can say it is adenoma. However, in adenomas, their round, smooth margin will be there, and there won't be any necrosis usually. And they are usually lipid rich, but of course, we can have lipid poor adenomas also. And if the Hounsfield unit is more than 10, we have to think of either pheochromocytoma or adenocortical carcinoma. More than 20 is more suggestive, actually, more than 20 Hounsfield units. Then on washout, we have to see, actually. A classic adrenal CT consists of we do an unenhanced CT, and at 60 seconds, that is 1 minute, we post contrast, we do the CT, and also at 15 minutes we do. So we calculate what is called the absolute and relative washout. So that is enhanced early minus wait, early minus E minus U. We calculate the if the both the absolute and relative washouts. Now 50% is taken as cutoff. Earlier it was absolute if it's more than 40% and relative more than 60%. Then it suggests more of adenoma. Actually, the washout will be better in case of adenomas. And in MRI, there is in pheochromocytoma, the classic light bulb sign will be there. In T2 hyperintense, then chemical shift MRIs are helpful, so that is mentioned. That is there is signal drop in case classical signal drop on out of phase imaging in case of adenomas, which are lipid rich actually. Sir, and Electrolytes give us a clue. And
would like to tell us something about your experience about these incidental as you were saying that.
so my experience. Who's?
No, Dr. Vivian, Dr. Lin, yeah.
Yes.
Sorry. Okay. So basically, for us, I have to say your two cases, wow, I would say they're incidentally discovered, even if I put my hand on the abdomen. It's really huge, really big. Generally, what I get in my practice wouldn't be an ultrasound, because in the ultrasound, you actually get to see only huge nodules, not small ones. So the ones that come into problems is I get it on the MRIs, I get it on PET CT scans, even I get it on CT scans. So you can get things, anything from 0.2, 0.3 centimeters upwards. So the majority of them, I get them will be less than 2 centimeters, 1 centimeter even. So the question then is, what do you want to do? So my approach would be, I have to see two things. I want to decide whether I have to take this thing out. It's a very practical approach. So if I want to take it out, is it malignant or not? So number one, I see on the CT scan, and the CT scan is great because it's going to give me the characteristics. Both, as she mentioned, Dr. Bhat mentioned in terms of the washout, the absolute washout 50-60%, as well as the Hounsfield units. That would tell me and give an indication whether this is malignant or not. So it's quite obvious what is malignant. If it's going to be high contrast, the washout is low, Hounsfield units are high, it's going to be irregular, it's huge. That's something that I worry, especially if it's more than 4 centimeters. So those, I want to take it out. Number two, I will also take it out if this is a functional adenoma. So the second approach would be, how do I approach finding out whether this tumor is functional or not? And actually, the great majority of them are not functional. So then once you have found out whether it's functional or not, your primary aldosterone, your testosterone, even estrogen, pheochromocytomas, and cortisol, and this huge group of autonomously producing cortisol. And that's a very, very gray and big area. When do you then decide this autonomously producing cortisol is justified, is great enough for you to then go in and take out the tumor? Then after that, once you've decided whether you're going to leave the tumor in, you're going to take it out, what are you going to do with regards to follow-up? How are you going to follow up? So that's my approach to an adrenal incidentaloma.
But how do you follow them up?
So again, if it's we have decided not to take it out, and everything is non-functional, so I would say for this group of patients, I would do it yearly. So if I had a CT scan ready, I might want to spare them radiation. So probably the next one would be an MRI, or a non-contrasted CT. Again, it depends on how confident I am about my first CT scan. So that's the first thing about what is the modality to follow up with. With regards to the functioning capacity, generally, if this is a non-functional tumor, the only thing that I might want to do for them would be an overnight dexamethasone suppression test, and I'll probably do it for the next 4 to 5 years. And because they have been known to convert in the next 3 to 4 years to something which is autonomously producing. So that would be follow-up. But the problem now becomes, what happens if this is a 20, 30-year-old lady or guy? What do I do in 10 years' time? Do I keep following them up? And I think nobody has been able to answer that question yet. So I would go by common sense. The more confident I am that this is it's a benign, it's a non-functioning tumor, I might just want to maybe in a few years' time just do an ultrasound where that is non-invasive, it's cheap, it's easy to do it. So there we go. I wouldn't lose them to follow up, but I wouldn't do it closely anymore.
Yeah, I have one query to Sowrabha. In this patient, if you see, the history was very classical. Retrospectively, if you analyze, the history was very classical, that patient is hypertensive, patient had recurrent episodes of hypokalemia. So probably if history is taken properly, probably we won't say that it's an incidentaloma. It is probably a patient who has investigated for hypertension. But in this patient was investigated for some pain in abdomen. And that's why probably it's an incidentaloma. The important question here is, if you see the ONDST in this patient, it was 5.5. So how do you explain it, and have you checked it after the surgery? Have you
Yes, sir.
done the recheck it?
Yes, sir.
Check.
Post-surgery it was suppressed. So probably it's a co-secreting adenoma, aldosterone and also minimal like cortisol producing. Actually, and ultrasound was not like she underwent repeated this thing and ultrasound it was picked up in a other setting. So she maybe directly if she was referred to ours,
Yeah, yeah.
have picked it up.
No, but then in this patient, if you see ONDST, though it was not suppressed, pre-op, have you done some investigations like LDDS or ACTH to evaluate whether it is secreting, co-secreting adenoma, or it is false positive test? We know ONDST it's known with ONDST we do get false positivity almost in 30 to 40% of the patients. We do get false positivity.
Yes, sir.
So that's important thing which I feel we should have ruled out, because in long-term follow-up, that's an important issue.
Yes.
Can that also be classified as a subclinical Cushing's, because
Possibly.
that range is considered to be a subclinical Cushing.
Yeah.
That range
Even the stress of this illness can gives rise to false positive results.
Correct.
Yeah.
I think actually the important message from that first case is that basically that every case of hypertension who has hypokalemia and who has this recurrent, you should be looking out for in this case, we should have actually worked up for cons, because even though the hypertension was not difficult to manage, the odd point was that hypertension is not very difficult to manage. Generally, we expect the hypertension to be a little difficult to manage, and then
Resistant.
you go on to investigate that. So in this case, probably it's controlled with two antihypertensives. Never considered as an important factor to be investigated, and that's something which probably we should understand, that probably it give us a sort of two towards cons.
Second case was very classical.
Yeah.
Actually, before I just have some comments to make on the first case.
Yeah.
Because it's so classical, I don't want people at home or listening to this to think that you need to have hypokalemia, because actually the minority of patients with primary aldosteronism, okay, actually have hypokalemia. And even for Cons syndrome, they might not present with hypokalemia. Now, I have to say that this case is 3 centimeters. As you know, the mean size for Cons syndrome is not 3 centimeters. So this is pretty florid and pretty large. And I quite agree with my other co-chairs that I was quite surprised that the hypertension was so well controlled. But you do have quite florid hypokalemia. So that's one thing. If you look at the renin and aldosterone ratio, that was off the rocker. I mean, I need a minimum of 15 nanograms per deciliter. And the ARR ratio would be a minimum I use about 20. Now, some people use 30, some people use 40, but it's about there. This is off the scale. So this is really florid. So which brings me to the point about when I go for surgery in a 52-year-old woman with 1 tumor showing there, but a pristine left adrenal gland. Now, in the teaching, in the discussions, if I'm seeing 1 centimeter, 1 to 2 centimeters, I'm not going to be so confident to say that I'm going to go for surgery. So that's the point that I wanted to make, because in most of the cases, we're going to have this discussion about whether we're going to do an adrenal venous sampling or not. Because in 50% of the cases, we do know that adrenal venous sampling would change the diagnosis to a bilateral to unilateral. But because in this case, it was 3 centimeters. It's so florid. Look at the aldosterone. Look at the potassium. So because of that, there might be an option, of course, with the blessings and with discussion with the patient to say that we're never 100% certain, but with this case, chances are, this adrenal tumor is a Cons syndrome. It is causing the problem. And indeed, it was a good judgment call, because without the AVS, we went in, it got taken out. The hypertension did improve, and the hypokalemia got cured. So basically, you have cure of hyperaldosteronism. But note that the blood pressure did not get resolve totally. And this is also in keeping, in this case, it was so florid. And yet at the same time, despite the fact it was such a florid, severe hyperaldosteronism, after curing, you still require one antihypertensive medications. And in the majority of cases, this is what we are seeing also for these groups of patients. And the older they are, the higher the chance that you will not be able to cure the hypertension despite curing primary aldosteronism.
There are some questions from audience as well. Dr. Samir, can you answer how to convert direct renin concentration to plasma renin activity? PRA.
I think, sir, this plasma renin activity and this plasma renin concentration, these are two different things. Whenever we are calculating the aldosterone renin activity ratio, I think we should more rely on the plasma renin activity. There is no formula as per my knowledge where I can convert renin concentration into renin activity. These are two separate things. The plasma concentration of the active form of renin is usually measured by the radioimmunoassay, but you can also measure by automated manometric assays. That is my take on the plasma renin concentration. Whereas plasma renin activity, if we talk about, it is measured by incubating plasma and without addition of some angiotensinogen, which is a renin substrate. So relying on the endogenous angiotensinogen in the plasma. So that is how you measure plasma renin activity. So that is these are the two different things. One question I want to ask Dr. Sowrabha regarding the first case was that you had an unsuppressed ONDST. So how do we explain this?
Sir, actually, cortisol production, co-secretion may be there with the patient.
So how will we prove it? It is a co-secreting aldosterone producing adenoma plus cortical secreting adenoma, because the clinical features, the biochemical features, and the post-operative things are very different in co-secreting adenomas versus single adenomas. So I think that's one of the interesting things we should learn, that whenever you have these co-secreting aldosterone plus cortical secreting adenomas, you have more hypertension, more hypokalemia in these patients. Plus, there are some hybrid steroids where you can measure biochemically, like atrial hydroxysteroids, urinary ketosteroids, which are increased in these patients, which will not be increased particularly in pure aldosterone secreting adenoma. There are some other features. I think there are a couple of cases, some case series also, but immunohistochemistry, these clinical features and the biochemistry differs, and we should be very sure whether it is a pure aldosterone secreting adenoma or it's a mixed one.
I feel that's why I said probably the chances of false positivity are very high in this patient, as we are talking about two different cell lines from the adrenal gland which are involved simultaneously for one tumor which we are seeing. The chances are usually less in such patients when there are no florid signs of Cushing. So possibly the chances of false positive ONDST are very, very high in this patient.
Yes, sir.
There is one more question from the audience. If the adrenal, which I think Sowrabha has already answered, but Dr. Samir, if you can explain it in details, if the adrenal mass is heterogeneous with variable density, what will be the Hounsfield unit value of the mass? Is it the average value? I think Sowrabha has already explained, but then you can explain once again for the audience.
I think, sir, this Hounsfield density unit issue, I always leave on to the radiologist. But what my concept is that when you have an attenuation value less than 10 HU on an enhanced CT scan and a rapid contrast medium washout, it's very likely to be a benign adenoma. When you have attenuation values more than 20, I think it can be carcinoma, metastasis. So you have to see for other things like tumor calcifications also. And in pheochromocytomas also, you have unenhanced CT attenuation values less than more than 10 HU. So it can be anything. So you have to see for other characteristics. like the delayed contrast medium washout, tumor calcification, the size of the tumor. But less than 10 HU and a smooth border and a rapid contrast washout is a benign adenoma. That's what concept I have.
Just a little addition to that. So I had this discussion with my radiologist, luckily. So they tell me they don't like small tumors because it's not the average, but you need to have a clear field when you put your little circle so that they can give you the Hounsfield unit. So if you can't get a little clear circle there, that would not be so accurate. So of course, the bigger it is, it's easier. But having said that, for the bigger ones, if you have heterogeneous, that's going to be a little bit difficult as well. Now, conversion, people kept asking the thing about conversion. As Dr. Samir would say, it's correct. They are totally different things and calculated differently. But because the direct renin concentration is so easy, a lot of people want to use it. But remember our data from decades in which the ARR has been calculated. It is based on the plasma renin activity. So yes, you can convert. I think it's sometimes 8 point something. Yeah, you can convert. You have apps that convert. But then how good does that conversion mean to you? So I would personally still do a plasma renin activity. And because Singapore and Mayo Clinic, we're quite close. We always train there. So we sent our 24-hour, we sent our renin and aldosterone directly to the Mayo Clinic. And if it goes in bulk, the bulk pays for the transport. So it's actually not that expensive. So our renin aldosterone comes from there, and they have it in the OPRA, the plasma renin activity, and we can calculate the ARR based on that. So I'd rather do that than to convert or then to get direct renin concentrations unless I have more data about it. There's no right or wrong. It's just a personal preference that I do.
Yeah, Dr. Vivian, you have told us just now that you are seeing a lot of patients with very small tumor, maybe 0.5 centimeter to 2 centimeter.
Yes.
But in many centers in India, we do not have facilities for adrenal venous sampling.
Okay, yes.
So if you are suspecting primary aldosteronism, especially in such patients where tumor size is very small, maybe 0.5 centimeter, so how do we go about in these patients when facilities for AVS are not available?
That is $1 million question that everybody's trying to answer. So it really depends. The data that comes out that let's say it's a 35-year-old and less, because the risk of having an adrenal adenoma is very much lesser than someone who's 60 years old, say. So if you have got primary aldosterone, ARR positive, we have got a tumor there one side and the other side is pristine. You've got hypertension, you've got all that, everything classical. They're less than 35 years of age. There might be a case to be made that we go and take that tumor, okay? But that's in a young person, okay? Or in that 52-year-old. We're talking about extremes here. Look at how florid she was. I was quite 99% certain that that was going to be the tumor that caused. But everything in between, that's going to be a big, big problem. How certain are you that that tumor is going to be the one which is responsible for primary aldosteronism? And that's where AVS comes in. We have got lots of studies now coming to new technology to find, for example, a metabolite CT scan that's in the centers in Singapore. But we need more data and more studies in order to tell us whether that's the way to go. It seems pretty promising. But, you know, we are still not 100% there yet, but it seems pretty promising.
Yeah, so there is one question for you. How do we take samples for renin aldosterone? What are the prerequisites? How do we collect samples?
First of all, we should make sure that the patient is the potassium level is normalized, that is more than 4, that supplementation, and adequate sodium intake should be there. And you should check whether any mineralocorticoid receptor agonists or any diuretics which cause potassium wasting diuretics are there. Then they should be stopped for at least 4 weeks. Then patient should be in the supine position, and we have to place the sample, we have to draw the once the patient is taken off this medication which interfere with this, then we have to draw the sample and with the patient in supine position, and it has to be placed in ice packs, actually minus 20 degrees ice packs, and then it has to be transported to the lab. But we used to send the patient to the lab because the facilities was the issue. So if possible, if with permission, we send the patient to the lab in our setups. So we would not draw the sample ourselves. Like we used to send the patient to the lab where it was drawn.
Okay. Okay.
Would you like to give us your views on the case 1?
Final comments.
Samir, your comments and take-home points to the table. Case 1, then we'll.
I think yes, sir. We have discussed a lot of things about this, but any patient who is coming up with hypertension, hypokalemia, and you have an adrenal mass more than 1 centimeter, I think we must rule out hyperaldosteronism in these cases. And if you have a suppressed renin activity and a high aldosterone, I think that's a very high suspicious for primary hyperaldosteronism. Then we have to prove hyperaldosteronism with various tests, which can be salt loading tests or other tests also. So normal saline infusion tests also. Young patients, clear-cut adrenal mass and high plasma aldosterones with suppressed renin activity, I think we can directly go for the surgery in these cases. But sometimes you have adrenal hyperplasia. So in that case, it requires some medical management. So we have to be very sure whether we are dealing with a unilateral adenoma versus adrenal hyperplasia case. So that's, I think, will involve a full day of 1 hour or 2 hours of talk on these issues also. So good case, I think.
We must so excellent.
Yeah. Excellent presentations. Yeah.
So can we have discussion on Pheochromocytoma now?
Vivian, doctor, would you like to tell us something about your experience about POs?
I have to say, this patient was really florid. It's 9 centimeters. I don't even need an ultrasound, And I was surprised that she has nothing. She has no symptoms whatsoever. How does it happen? So in this case, for adrenal incidentalomas, I have to say, the incidence of functional adrenal, for adrenal incidentalomas, functional is 10 to 20%, okay, depending on what studies. The European study, which was quoted, seemed to be rather high, but in my experience, it's probably about 10% for functional, 10 to 15. The minority of them is going to be pheochromocytomas, because in general, if they're going to be 4 centimeters above, likely they're going to be symptomatic. The smaller ones that we're concerned with, the ones where I talked about, like about 0.15 centimeter, 1 centimeters, they're not going to be florid, they're not going to be symptomatic, and the minority of them would be pheochromocytoma producing. So, but I would definitely still have to go through functional analysis, and that would include pheochromocytomas. And so what I would do is a 24-hour urine fractionated urine metanephrines as well as the catecholamines, and then wait for them to come back. Again, for these, I actually send them to the Mayo Clinic. So it's mass spec. Then the levels that you have given, those are the cutoff levels that I'm seeing as well. So with those cutoff levels that I'm seeing, this is without doubt, this is definitely a normetanephrine producing tumor. So it's pheochromocytoma, and we're going to take it out. For this case, what's most important is going to be the preparation pre-surgery. And she's 30-something, she's only 32 years old, am I right? So that's fantastic. I normally use phenoxybenzamine because I find in these florid cases, if I'm going to use prazosin, I'm going to see that surges inside intraoperatively. When I see, whereas if I use phenoxybenzoamide irreversible, it's going to be much, much calmer and gentler, especially since she's 32 and I can give the highest dose. So I can just go higher and higher and higher until she feels symptomatic. When I say symptomatic, it's in staff nurse. I don't even do the blood pressure because that's going to stop me from giving. They're going to be so worried about it. So I'm just going to give them to the highest dose as possible, about 90 to 100 systolic, about 100 systolic. She's young, she's 32, and give them lots of fluids, lots of sodium chloride, so that it's all filled. So the minute the Pheo comes off, I don't see that big drop in blood pressure. That means that I have not preoperatively prepared her well. So it'll be interesting to see post-operatively, intraoperatively, if you could tell us what happened to the blood pressures, and also post-operatively with prazosin, what happened to the blood pressures as well.
Yes, ma'am. Intraoperatively, actually, we asked it. We asked the surgeons. Actually, I didn't attend the surgery being happened, but it was smooth. There was no fluctuation. Actually, we don't use phenoxybenzoamide in our setup, ma'am. We use actually prazosin only. 5 mg, then 5 mg twice a day. Like we progressively increase it till we reach the target, actually. And we load them with the fluids, and we give beta blocker and extra salt, added oral salt, and prepare them. So intraoperatively it was smooth. We have other cases where there were catastrophes, there were flash pulmonary edema, and the BP dropped and there was bleeding and all that. But here it was smooth. And post-operatively also the BP was normalized. We didn't have to put her on any antihypertensive at all, actually, post-operative.
And there was no blood pressure surges intraoperatively. That is wow. you have atypical cases.
Details actually I don't know. It was just that I have found out whether it was eventful, because we had lots of Pheos, ma'am. Actually, surprisingly, like you mentioned, we have such big Pheos, bilateral Pheos also coming totally asymptomatic, and BP also being normal, actually. So we lost one patient of VHL actually on table and all that. But I frankly speaking, the exact fluctuations I have not, I didn't witness the surgery. Sometimes used to just get into the OT, but for some cases, but for this case I have not. But overall it was smooth. There was no post-op hypotension. It was smooth.
Okay, so good pre-op preparation.
I have one query on similar issue. Like in this patient, if you see the tumor size is huge, almost 9 centimeter size, and probably she is asymptomatic till date. It was an incidentally detected Pheochromocytoma. So how common is it for your situation?
Not common at all.
Yeah,
this is not common.
Patients.
No, I mean, I mean, because she mentioned, Dr. Bhat mentioned that it was uneventful, but it's not the same as there were no BP surges, and it was a very good anesthetist. So we always get very good anesthetists who deal with pheochromocytoma. So it could be that there were blood vessel surges at the points in which you have, like, for example, intubation, for example, induction. These are known. When you clip, when you touch it, these are known, and I'll be quite surprised that there's not even a single surge. So probably it might be there's a surge, but the anesthetist was great. They just reacted very quickly. As law intravenous, and so it is uneventful because it wasn't surge out there. They were able to catch it. And if your pre-op preparation in terms of the saline, in terms of that was good, and prazosin, to be honest, post-op wise, I'm not going to be expecting hypotension, especially if the pre-op was good. But phenoxybenzoamide, yes, especially if the pre-op preparation is not good.
Ma'am, one more thing I would just like to mention, actually, surprisingly, ma'am, in our setup, we have seen a lot of Pheos. I would not say exactly incidentalomas, but of course, spells. Hardly any patient used to present with spells. A lot of them with normotension. They don't have hypertension at all. So they say that large chronic stimulation can cause what is called adrenergic receptor desensitization. Maybe that is a phenomenon. We have seen in a lot of patients, actually, not classic presentation and like this, ma'am, asymptomatic.
Now, I have one query. As she said, this patient was asymptomatic. probably though she was hypertensive, but then we see a lot of patients who are normotensive, but they biochemically they are pheochromocytoma. Clinically, their blood pressure is absolutely normal. So how do you manage these patients during intra-op period? Do you see still any
Yes.
surges in blood pressure in intraoperative period, and how do you manage?
Actually, yes, absolutely. We treat them the same as whether they're symptomatic or not, whether they have high blood pressure or not. We do know, especially with the syndromes, they can, especially small ones with the syndromes, they can actually be normotensive. So the classical presentation of intermittent high blood pressure is not exactly a myth, but it's not 100%. So I still treat a pheochromocytoma with great respect. So long as it's a pheochromocytoma, I alpha block, a beta block, I give lots of fluid, lots of sodium chloride, same treatment, treat them with respect.
Samir, I would like to know your experience about pheochromocytomas, especially such large pheochromocytomas who are asymptomatic and who are probably normotensive. How do you manage at your center, and how many patients do you see such large pheo with asymptomatic?
Yes, sir. Actually, luckily, if I find that how many views I have seen in past 5-6 years in my post DM clinical experience, I feel that most of them have been symptomatic, except for a couple of them. One was a pregnancy and few that was a real challenging case for us, where it was not showing any hypertension, maybe because of the concomitant pregnancy, and we operated this patient in the second trimester of the pregnancy. And most of these patients which we encounter have been hypertensive, have been having typical symptoms of tachycardia. Yes, they do not have that episodes of headache, sweating, and palpitations typically, but yes, many of them. But I think most important is the pre-operative management. We usually do it with vasopressin, and we do a good amount of hydration in these patients and give them salt also. And then we have a dedicated endocrine surgeon with us. So we do it like 10-15 days of good amount of, I think that's very important to have good pre-operative preparations in these cases. Another thing is that we are usually doing MIBGs in all our patients also. So that's one of the things. Whereas the textbooks write is you have a typical pheo, and with biochemically proved things, you do not require, I think, MIBG also, but we are doing this since we have got the facility of doing these things. And now I think Dotonok seems to be more sensitive in these cases as compared to MIBG. So the question again then that left unanswered is whether we do a genetic screening or not. What I have read on in the literature is that yes, we must do a genetic screening, I think, in almost all patients of pheos, especially in young patients. So how to do this? I think we have to stratify. This was one of the questions also which has been put by one of the audience, I think, today. I think every time I have to answer this question, I have to go to a flow chart. I have to open my book. But whatever concept I have in my mind is that most important is whether it is an adrenal pheo or is it an extra-adrenal pheo. So if it's an head and neck, then your list for genetics testing is somewhere at B and D SDH mutations. If you have an adrenal pheo, then look for the biochemical predominance, whether it is an adrenaline, noradrenaline, or a dopaminergic. So if it's an adrenergic, you go for a RET mutation. If it's a noradrenergic, it's a VHL. And if it's a dopaminergic, I think it's again, these SDH mutations come into play. And normotensive pheos can be associated with dopamine secreting pheos also. And if you have that typical symptoms of neurofibromatosis or VHLs, then definitely your point of genetic testing gets limited to a couple of things also only. But I think you have to read that flow chart. I cannot answer here. But I frankly telling you, we are not doing genetic analysis at the moment.
Let's learn.
Expensive. It's expensive.
Yeah. What about genetic testing in Singapore? Are you
expensive? They are all expensive. All those genetic molecular things, the thyroid molecular analysis, all so difficult. Yeah. But I mean, we do. But I would agree that we have to do it for her because she's 32 years old. I'll take I'll take a detailed history from her, you know, to see whether there are any, you know, familiar histories or not. Yeah. And 9 centimeters, I'm worried. I worry about metastasis, basically. So you told me that it was cleared fine. You will have to keep following this person up. It would be nice to know also the histology. What's the grade like, the Chi-67 or any other grade of high-risk grade, whichever your pathologist wants to use to decide on what is the risk of metastasis of this patient in terms of the histology, because it's 9 centimeters.
So what happens with so large tumors, Dr. Sowrabha, is that sometimes they take a lot of MIBG and the metastasis do not take up in the pre-operative scans. So it's a good idea if you can repeat on the post-op whether DOTANOC or MIBG, because now the main lesion is gone. So if you have a small lesion, that will take up MIBG or DOTANOC. So not a bad idea to do a scanning post-op.
Yes.
With the permission of Dr. Rakesh, I would like to discuss one more case which I am following right now on this forum because I feel this is the right time. Recently, I had come across one patient who has been operated for MTC, medullary carcinoma thyroid, almost 8-9 years back. And she was then disappeared. She did not follow any center. She came to our center recently in the 4th month of gestation, 4th month pregnancy. And she incidentally found to have bilateral pheochromocytoma.
Oh.
Absolutely asymptomatic. Blood pressure is absolutely normal. We started alpha blocker, but we had planned to operate her somewhere around between 5 to 6 months. She was very unlucky that during that time she got COVID.
Oh.
Our anesthetists were not ready. She had bilateral chest lesions also, though she was asymptomatic. We could manage her. She's off her COVID. She came out of COVID, but by that time it was almost end of 6 months. And now this time our surgeon said we can't do laparoscopic surgery. If at all we need to operate, and that to bilateral exploration in an asymptomatic patients, he was afraid. Her blood pressure is still maintained. We sat together and we have taken decision not to operate her, continue her pregnancy, and maybe by 28, 29 weeks, we will take call. Right now, she is 23 weeks. How do we go about in this patient?
Very difficult. Yeah, I think you've done everything right. I wouldn't want to be in your shoes. It would have to be.
And you won't believe her bilateral pheochromocytomas which were not picked up. Maybe she has not followed up anywhere. That might be the reason. They are large, 6 to 7 centimeter tumors on both sides. Quite big tumors.
When she first got medullary thyroid cancer, how old was she?
She was almost 12 to 13 years old, and it's now she is 24 years old.
12 to 13 years old. Oh,
never followed up anywhere.
Okay, so she was 12 to 13 years old. Okay, so that's almost definitely this is men. I mean, this is a syndrome. Yeah. So, yeah, I don't know how that came about that they didn't pick it out. It will be a pre-pregnancy, you know, discussion to be had. That before we go there, we definitely at the very least.
With pregnancy. Patient came to us with pregnancy only. He came to me for the first time. So it's extremely difficult for us.
So therefore, you need to plan the pregnancy. The person who took care of the medullary was supposed to. Why don't you get it back to that patient, that doctor, and see what they.
Samir, I would like to know your experience. You said you have managed few patients with pregnancy and pheochromocytoma.
So, Dr. Pramod, we just had one patient with pregnancy. In fact, she was pregnancy and she had some pain abdomen, and I do not know how she landed up to me, but there was, and during her workup, she had amenorrhea. We did UPT and it became positive, and then we picked up the things. She has also underwent CT scan and there was a adrenal mass, and biochemically she had clear-cut pheochromocytoma. So but luckily she was normotensive. At no point of time she had any tachycardia and this. But we tried to, since even the normotensive Pheos, if left unoperated, have a bad outcomes at the time of the antenatal period and also at the time of delivery. I did a lot of literature search on this. So we decided to operate on this patient. Luckily, by the end of the second trimester, it was just ending. She was operated and we took out, and we have this typical gel ball pattern on histopath, and her biochemistry also came down to normal post-op. She delivered a baby boy a couple of months back. Now she is doing fine, absolutely.
Great.
But yes, it's a real challenge actually to do these things.
So, Dr. Pramad, you said that she was in 23 weeks. So she's still second trimester.
Right now she's 23 weeks.
Okay. But she's COVID done. She's done, right? With COVID already, right?
Just 3-4 days back only.
Okay. So why? So question: why can't your surgeons go in?
My neurosurgeon is saying at 23 weeks, since it's bilateral Pheochromocytoma, there is no point in operating only one side. We need to operate both sides.
Yes.
At the gap of at least 2 weeks. So that's the reason he is saying it is difficult at this point of time.
This is a very tough situation. You really need to sit down. I mean, it's going to be a trite discussion because you have to sit down with multiple people, including the patient and all the family members, because they need to know if you let it be through to pregnancy, what are the consequences as opposed to now? If I take out both, now I have to give cortisol at the same time. She's going to be adrenal insufficient afterwards, you know.
Yeah.
And in this situation with COVID and all that, this is very difficult situation. There are no right or wrong answers, you know.
Yes.
I think you're doing your best.
Yeah, a lot of depends on your surgeons, whether they are comfortable or
We
not.
had planned everything, but unfortunately this COVID had made the whole mess in this case. Sowrabha, have you ruled out MEN in this patient? It's a large PO.
Yes, sir. VHL testing was done, not like it was done in this patient. A group of samples were sent. They don't do in our center, but we had sent to SGPGI actually. A lot of patients were called and it was sent. So VHL was negative. VHL was done because it was predominantly norepinephrine was high.
I think
but it's not done, sir, actually.
Yeah. There are a lot of questions from the audience as well. I think we should read out those questions. Genetic analysis, I think Samir has already answered.
I think many of the questions have been answered.
Yeah.
I think someone was asked, or said our panelists, because I noticed that the functioning, we talked about primary aldosteronism, we talked about pheochromocytomas. We didn't talk about the biggest pool of functioning tumors, which is the big one with lots of gray spectrum, which is the autonomous cortisol producing ones. So shall we, we don't have a case history, but shall we talk about that? Dr. Bhat, you can start because you always started the case history. What happens? What do you think now? Now we have shifted. Now we've gone to cortisol. We can use that case. Just minus the fact that she's primary aldosteronism. Just take that one. 5.5. And then start from there.
So if it is suppressed below 1.8, then we can rule out autonomous cortisol secretion. But if between 1.5 and 5, then it may be minimal cortisol secretion. But here it is obvious actually there was cortisol secretion, but like Dr. Samir mentioned, we had not done the other tests actually. It is not properly worked up for post secretion. But post surgery, it was suppressed.
Oh no! I mean, we're using this case as an example, 5.5 as an example. I mean, so therefore, there is this is an incidentally discovered tumor, right? And now you have done all your functional testing. You know it's adrenal adenoma. You know that the Spheo was negative, primary aldosterone was negative, ARR was negative, DHEAS was negative. Now you do your overnight dexamethasone suppression test. So what do you do now? You know, if, as you rightly pointed out, less than 1.8, that's negative. More than 5 micrograms per deciliter, actually, that is, we need to go forward and we need to diagnose. So, you know, you can do your low dose dexamethasone suppression test. But what about this group of people who is between 1.8 to 5? What are we going to do for them? You know, what, and then this big term of subclinical Cushing's. So what do we do for this group of people?
We should look for comorbidities like hypertension, diabetes, osteoporosis. Yeah. It may be because of that, it may not be. Although she was hypertensive, she was not diabetic. And the BMD was normal. Of course, not in this case. In general, we have to assess for the other effects of subclinical Cushing and confirm that with an EPIC. And we have to check for its dependency actually before planning any surgery. It's a very dicey situation whether the surgery will help decrease the comorbidities or.
I think here the question is, if at all it is subclinical Cushing's,
I think I'm going to ask some. Wait, can someone? All those who are not speaking, can you mute? Because I think we can't hear Dr. Pramod.
The question here is, if at all it is subclinical Cushing's, how are you going to manage? That is a question. Clinically we have evaluated. How are you going to proceed further in this patient? Suppose if it is say ODS cortisol of 4.5, clinically patient does not have any signs of Cushing's. All other tests like primary aldosteronism is ruled out, your Pheo is ruled out, and your ODS is positive. How are we going to do? That's a question. Am I correct, Dr. Vivian?
Yes, correct. Yes, correct. So basically this group of people in which, how do you diagnose subclinical Cushing's? What are these classifications here? So if you have, because like this florid signs, if you go backwards to the history retrospectively, chances are some of this group, they are not subclinical anymore. They're classical. It's just that we might have missed it, especially those in which is low dose, if you have confirmed that this is definitely Cushing's already. It's more than 5. You've gone on some more. You have confirmed it retrospectively. You see that actually it's actually classical. We just didn't get it beforehand. So in that situation, there is a small group. Certainly, there's no discussion. It's going to be surgery because we are treating it as classical Cushing's. But what about this group where subclinical Cushing's? First off, it's so amorphous. What is this group of subclinical Cushing's? How do you diagnose subclinical Cushing's? And subclinical Cushing's means that it's not overt. There are no classical signs. So subclinical. And so this is the group which is between 1.8 to 5. And what are the tests? And I think there are different studies that come up with different tests. One is using the ACTH, one is using a DHEAS, one is using the overnight DEXA. And let's say if all amorphous or somewhere in borderline, what then are we going to go for this group of people? And that's going to be very difficult because even if we saw all the comorbidities, especially in this patient who's 52 years old, let's say she's slightly obese, she's 52 years old, she's got diabetes, high blood pressure, osteopenia. But what does that mean? Because there are many patients who also have this chronic disease. Does it mean that if I send them for surgery to remove the tumor, which was incidentally discovered, that means you are going to have a reversal and cure of all these? So the answer is not simple because they might not. So how do you justify who is the one that you're going to identify for surgery? I think that's another big topic for discussion. So I think that would be great to hear, you know, from my other co-chairs. What do you think? How do you decide who are the ones for go for surgery? What is your approach?
Rakesh, you need to unmute.
Samir was.
So I think, yes, it's a difficult challenge. The question which has been put by Dr. Vivian is what to do with those people who have an ONDST between 1 to 5, whether to go for surgery or not. I think it's a real challenge. In fact, what is my practice is I will do a LDDST in these patients also to confirm what's happening to LDDST. That seems to be more, I think, sensitive and specific also as compared to simple ONDST test in these patients. And whether these lesions have glucocorticoid secretory capacity, I think again it's a challenge, but there are some markers for it, like patients having osteoporosis, subclinical Cushing's. So you have, I frankly telling you, it will depend upon the biochemistry with further confirmatory tests. So how are these? But no clear-cut answers to this.
Yeah, I would also go on to doing a LDDST in these patients. Try to exclude hypercortisolism, which is and in those whom LDDST is suppressible and ONDST is still in that range, are the ones who are going to be a challenge of how to manage them.
Yeah, I agree with what my co-chairperson, Dr. Rakesh, has said, that we would like to do LDDS cortisol in this patient. And in a setting where you find that patient has clear-cut adrenal adenoma, which is seen, along with ODS, which is repeatedly positive, LDDS is borderline or maybe less than 1.8, probably we will subject these patients for surgery, and adrenal tumor should be out. But many times we see that there is no obviously seen adrenal tumor. In such patients, we need to follow up these patients on regular basis, both biochemically as well as imaging should be done on regular follow-up. I feel that's the uh, way out in such patients. How do you follow up at your center, Dr. Vivian?
No, it's the same thing. I mean, we all have grappled with all this. You know, you've got even low dose dexamethasone suppression test, which is 53. You know, we go by nanomoles per liter. So 5.3. You know? ACTH is lowish. You know, subclinical, because subclinical being that they had no symptoms. She's not Cushingoid, or she might have mild high blood pressure, maybe a pre-diabetes, you know, bone is fine. You know, all this case, it's really difficult for me to send them, to be honest. It's very difficult for me to then say that, okay, I'm going to send you for operation now, just because your LDDST is going to be marginally positive, or like 60, you know, 5 or 6. So it's a discussion that I'm going to have with my patients, and I think there's no right or wrong answer, and that's why this is a big field. And I thought that I wanted to talk about it because primary aldosteronism, pheochromocytoma, yeah, okay, it's positive, off you go. 4 centimeters and above, off you go. But then this big field of subclinical Cushing's, this is something that nobody has the right answers to. I mean, and we are still trying to formulate how we're going to move forward.
Yeah, in fact, there was a recent paper in JCM 2020, I think, where subclinical Cushing's and adrenal incidentalomas, they had a very high atrial fibrillation rates as compared to the simple adrenal incidentalomas and otherwise. So I think diabetes, osteoporosis, and now with more data coming up with atrial fibrillations. This was a retrospective data done around 10, 15 years. Good paper published recently in JCM. So I think these should be the criteria to be discussed, as Dr. Vivian was saying, to be discussed with the patient, whether we can take them for surgery or not.
So in the it's going to be really whether that individual is going to progress, how fast they're going to progress, and how often they're going to end up with atrial fibrillation or with reduction in the bone density. And it's a real crisis, and I think we need to discuss, as Dr. Vivian said, that we need to discuss it out, individualize it, and look at various other factors in deciding how we manage them, and that's that.
I think there is the role of follow-up of these patients is very, very critical. That's very important. That's going to give us the answer in most of these patients.
Again, I think, sir, age is also one of the factors which should be taken into account. More elderly, 70 years, I think simple follow-up can do. But if the patient is young, 40, 30 years, subclinical Cushing's, you are suspecting, maybe you can take for surgery. Or if the patient is having these comorbidities like diabetes, hypertension, osteoporosis, and AFs. I think then the things need to be discussed. In fact, whatever review articles or there is no clear-cut answers to this, but these all things have to be taken into account.
So yeah, I totally agree. So individualized medicine,
Yes.
You do a baseline high blood pressure, or oral glucose tolerance test, a bone mineral density, and then you follow it up. And if you say if in 1 year a person who is 40 years of age drops 5% in the bone mineral density, that is not that great, So and if it keeps doing that, and it becomes atypical, then I think it has justified, the surgery. But as mentioned, if someone is 70 years of age, yeah, I might not want to go for any surgery anymore. So yeah.
So I think we had an excellent discussion. I would like Sameer to quickly give us some of the important points, take-home points of this discussion.
I think, yes, sir. It's very important to have a correct approach to adrenal incidentalomas in our practice. We must have a good clinical examination in these patients. That's very important, and to back up the investigation. When like adrenal incidentaloma, any CT scan lesion of adrenals showing a lesion more than 1 centimeter, and for the purpose for the CT scan, which has been some other purpose, and you find an incidental mass, and then you look for the blood pressure, you measure the electrolytes in these patients, you look for signs of Cushing syndrome in these patients. So if you have a hypokalemia, then I think you can go towards hypertension and hypokalemia, towards primary hyperaldosteronism in these patients. If you find hypertension, some stria, pre-diabetes or osteoporosis, then maybe you are dealing with some cortisol excess in these patients. And then if the CT features are suggestive of some irregular masses, calcification, and patient is hypertensive, you must rule out a Pheochromocytoma, either with a serum fractionated metanephrine or a 24-hour urine fractionated metanephrine. So that's how the thing goes. If it's a bilateral adrenal mass, then after ruling out Pheos, sometimes you require a CT-guided FNAC also in these patients, so that you are not missing at any infiltrative disorders, any tuberculosis, any metastasis, sarcoidosis, or histoplasmosis like lesions. So I think every case is you have to individualize. You have to do a chest X-ray also, so that there is no primary lesion in the past, especially in our settings in India, where we will find sometimes patients. So one of the recent cases where we had a primary adrenal mass, in fact, was suffering from antiphospholipid antibody syndrome. So that was the first case which we had encountered. So that is altogether a different story, that how can this antiphospholipid antibody syndrome can present with a bilateral adrenal mass. So every case I think is quite different. So you have to individualize, you have to stratify your workup in these patients, and then take a call.
Thank you, Dr. Lin, for her take-home points. What are the points you would like to give to the audience to carry home? And
so I have to thank all the co-chairs and thank you, the organizers, for this, and Dr. Bhat for that 2 beautiful cases on which we can springboard and discuss on. And given that, let's go back to it's adrenal incidentaloma. We discussed so much, and because it's so classical, we managed to discuss about even AVS. But let's say adrenal incidentaloma, the first thing, if it comes to you, first, is it decide whether you operate or not, whether it's functional or not, whether on a CT scan characteristic, whether this is a malignancy. So malignancy, operate. Functional, pheochromocytoma, primary aldosterism, classic Cushing's, operate. Subclinical Cushing's, discuss with the patient. Let's have that baseline. If we are not certain now, we are going to follow them up. And then in time to come, if it's justified, operate. Otherwise, if it's non-functional, I would follow up with an overnight dexamethasone suppression test for next 4 or 5 years. And it might convert from negative to positive, and then we go have the entire spiel in subclinical Cushing's again. And if, what about the imaging? The next imaging, if it's non-functional, if it's non-malignant, it dependent on what is the size. If you are borderline now, we're talking about 3 centimeters. Even if it's 2 centimeters, if there is an increase in size in the next 6 months to 1 year of, let's say, 1 centimeter, I would operate, especially if it's borderline. So that's one part. What about for the rest? If you're very certain Hounsfield unit is very low, this is an adrenal adenoma, my next scan is probably not going to be a CT scan. It's probably going to be an MRI. And if I'm very certain it's not going to grow anymore, perhaps 2 or 3 years later, I might do an ultrasound. So that's still iffy. That's still to be decided. So these are the follow-up characteristics that I would follow.
Thank you, Professor Lin. Now moving on to Dr. Pramod Gandhi. I mean, what are your final words, take-home message that you would like to give for today's?
Yeah, I think most of the things has already been summarized by our speakers and the panelists today. But I would like to tell you the 3 important things. One is any adrenal incidentaloma, we need to see 3 things, whether it is functioning, non-functioning, that has already been explained and that we have already discussed in details. Second, it is benign versus malignant. Now, I know in this group, a lot of participants are physicians, and whenever we talk about benign versus malignant, usually we talk about FNAC or some tissue diagnosis. Now here, in patients with adrenal incidentaloma, never do FNAC or biopsy at any cost. It's absolutely contraindicated. That's an important thing which I wanted to tell you. The benign versus malignant nature in patients with adrenal tumor is decided by the radiological diagnosis or CT scan. That's the only way, and probably clinical parameters those are going to decide whether it is benign or malignant. But never do tissue diagnosis in patients with adrenal incidentaloma. It's an absolute contraindication. And the third thing, by imaging, we need to find out the size, and probably size also helps us to decide whether we should go for surgery or not. Most of the tumors which are more than 3 to 4 centimeters in size, they need to be out irrespective whether they are benign, non-functioning, and those which are less than 4 centimeters in size, probably if they are non-functioning, benign, and incidentally detected, we need to follow these patients very closely to evaluate the further progress of the disease. I think that's all from my side.
Thank you, Dr. Pramod Gandhi. I think all of you have given very important messages, and just to crystallize it in 2 sentences, I would say that the most important thing is clinical examination. Clinical gives a good emphasis to the presentation, and then radiology is very important, and I think hormonal assessments. I think these are the 3 things that need to be done properly, and then that will help us in deciding whether to operate or not to operate. And Dr. Lin has all very clearly told us where we need to operate and how we need to follow up when we're not operating. And so, and the other important points that she has highlighted is the follow-up is very important. And once you decide about it, whether you can operate or not, it's not the end of it. So we need to follow up and see how the presentation changes and if the need for subsequent interventions that has to be done. So I think that's very important. I mean, I think we had a very interesting discussion. On that note, I would like to conclude and hand over the.
Thank you, sir. Yeah, sir, I would like to give a vote of thanks, sir. Very good evening once again, sir. Firstly, it has been a very engaging session for Adrenal Incidentaloma. My gratitude to Professor Rakesh Sai and Dr. Pramod Gandhi for helping guiding us and sharing this session under the banner of EPIC. A big thank you for taking time from your busy schedule, sir, for this session. Also, I would like to thank our international expert, Dr. Vivian Lim, and Dr. Samir Agarwal for being our national expert. My sincere thanks to Dr. Sowrabha Bhat for such an educative and enlightening presentation on the topic and equally interesting question and answer session. Lastly, I would like to thank all esteemed delegates for sparing time from their busy schedule and attending this webinar. We are looking for your participation in upcoming webinars also. A big thanks to all of you from Samarth Life Sciences. We are the makers of high zone, fluorocord, that is hydrocortisone and fluorocortisone